So many of us say, and I read it in so many advance directives or representation agreements that people show me, that they have one sentence or two that their lawyer is stuck in there, that if things don't look good for me, pull the plug, and I don't want heroics. And that is extremely premature. Most of us would want some heroics, and I'm going to go into what that includes. And it doesn't, it's for a time in the future, 10, 15, 20 years from now, and not what's happening to us right now. And so we're going to talk about heroics, resuscitation, and levels of treatment, and starting to talk about your preferences for future healthcare. I hope you'll join us next Tuesday for the final session on this portion of it, which is writing your advance directive. And I'm certainly around to help with taking this offline and helping you with your advance directive. And we'll talk about that more, because this is confusing and it's overwhelming, and it's okay for that to be that. I know that a few of you have joined for a few of these sessions, and I've got to say that I learn something about this almost every day. So you can find all of this information for free on the Patient Pathways website under Learn up at the top, and it depends on how big your screen is where that Learn will be, but that's what it looks like. And then you will go to Understanding Resuscitation, and there are several articles in there. So all of that's for free. If you've bought the book, all of this is in the book as well. So you can buy it all in one place. You can buy it as an EPUB book through all major retailers, including Amazon. And the print version is exclusively through Patient Pathways. The cost online is anywhere from $10 to $13, and for the print book, it's $30, which includes shipping. So that's where you can go to buy the book on the website. And that is it for me for selling my services. So we need to go back to the beginning and talk about advanced care planning for a minute. So in the previous session, we talked about representation agreement, which is the biggest one. The most important piece, besides having courageous conversations with your loved ones, and we're going to have more conversations about that tonight. A representation agreement allows you to legally name someone to be speak for you, and it is an important document even for people who are married or who have adult children, because the healthcare system is not obligated to talk to your substitute decision maker unless you have a representation agreement in place. An enduring power of attorney means a financial and legal document that is in place both while you are capable and when you are incapable. It doesn't have a lot of implication in a healthcare setting, but bills, when somebody gets sick, bills still need to be paid, rent still needs to be paid, and your power of attorney may need to provide your notice of assessment in order to receive either public or private home care or long-term care. So there are implications, and so it is a part of the advanced care planning package. The main thing we're going to be talking about tonight and next week is advance directive, sometimes known as a living will or letter of wishes for medical care, and I'm going to briefly go into that in just a couple of minutes. So where applicable, and this really applies tonight, is getting a no CPR, no cardiopulmonary resuscitation order in place. That's the same as a DNR, or do not resuscitate. More and more of the health authorities are now substituting or getting rid of the no CPR order and having medical orders for scope of treatment, even in the community, so that paramedics can follow that order as well. And then if you are expected to die, or if you might die at home within 3 months, of your expected death, you get an expected death in the home form available, otherwise known as an EDITH. It's really important that you put copies, not the originals, put copies of your advanced care planning documents on or beside your fridge. Some people, I have a little binder, a 1-inch binder that I have above my fridge, and a note on my fridge where I have it. I've got all the documents on the back of my door. The fridge is the universal place for where paramedics go to look for that. So even if you have your package of documents somewhere else, like in the freezer, which is waterproof and fireproof, or in the top drawer of your desk, or in the the cupboard below your oven or something like that, you need to put a note on your fridge where they can be easily found. We do not have a way to have a provincial repository that the healthcare teams will automatically look to. Some people will ask about NIDIS, which has a repository for these documents. Healthcare teams are not looking at those consistently. A lot of them don't know about NIDIS. And so it's up to you and your representative to make sure that your advanced care planning documents are delivered at every point of care. Please don't put copy. You can put your originals with your other estate documents. You can put those in a safety deposit box, but copies must be available, and your people, your representatives, or others who will deliver your health history need to deliver them at every point of care. I think that's one of the biggest issues for a lot of people is, why is it our responsibility? Unfortunately, that's just the way it is. I don't see it changing in Canada in the next while. In the United States, there are several states that are putting in place that doctors and hospitals must put these documents into a central repository that can be accessed by everyone. I think we're years away from that. And so it's up to us at this point. So as I said, it's up to you and your substitute decision makers or representatives to deliver your advanced care planning documents at every point of medical care. That means when the paramedics arrive at your doorstep, when you go to the emergency room, when you're transferred into and admitted to hospital, if you're going to home, if you've got home care coming in, if you're going to long-term care, all at every point of that, you might not need to deliver new documents, but you need to make sure that the staff have it on your file. So when I'm the navigator or a representative for somebody, I will phone when they arrive on a hospital unit, and I'll say, hi, I'm the representative for John Smith. My name is so-and-so. The representation agreement is on file. Can you go and take a look at that before we begin to have a conversation? We know more than most of our healthcare team will know. There is Vancouver Island Health and Fraser Health are doing an incredible job with advanced care planning. Vancouver Coastal Health in Providence, not so much. And so you need to let them know what your documents are. Sometimes that takes showing somebody 2 or 3 times, if not every time, that there are documents in place. So I'm going to briefly go into what a letter of wishes for medical care is. It is the form that I often use. I don't use living wills. They are not considered legal documents in British Columbia. They are falling out of favor. They have never been legal documents, and I'm not sure why they're ever used. I'm not a notary, but most lawyers will not use them anymore. It is a non-legally binding document, a letter of wishes. And sometimes that's a good thing. It is meant for those who have a representative or an alternate or substitute decision makers who will be able to be at your side, receiving medical information and helping to make decisions in real time based on your values and beliefs and stated preferences for care. It does not need to be witnessed or signed by a notary or lawyer. It merely needs to be signed and dated. This is the kind of document I have created for myself. My daughter is in healthcare. She's very assertive. I know that she'll be at my bedside so she can make decisions for me based on my values and beliefs in real time. But that's not an option for a lot of us. And so uh, for a lot of us, we need an advance directive. An advance directive is a legally binding document. It is appropriate if you do not have a representative or alternate or substitute decision makers, or they will not be able to get to your side quickly or at all. So if you are single and you don't have anybody, then, or your people can't get to you quickly, then it's really important that you consider an advance directive. It's important for those who feel that you can't have a conversation with your future decision makers. They don't want to talk about this stuff, or they might not honor your wishes. So if you've decided, for instance, that you would not want CPR under any circumstances, it's really, and they might balk at that or panic, then it's important that you put this document in place. It's important if you have preferences for healthcare that would not change no matter the circumstances, such as receiving CPR or being on a ventilator or receiving other heroic measures. And I'm going to go into that. It does not, with all legal documents, it can be a will, it can be your power of attorney, it can be this representation agreement. You do not have to have it signed by a notary or a lawyer. With that said, there are a lot of circumstances where we should have legal advice, and sometimes that includes a representative. But it only needs two witnesses who are not beneficiaries of your state, and most often that can be family or friends. What's really important is that a letter of wishes or an advance directive is only acted upon when you are not able or not capable of making your own healthcare decisions. So as we go through these things, you'll say, well, what about this? And maybe I want cancer treatments, or maybe I want dialysis. The vast majority of the time, you're still going to be able to make those decisions based on the information you're receiving from doctors. So this is not, an advance directive is not put in place when you are seriously ill and can still make your own healthcare decisions, such as cancer treatments, surgeries, early to moderate dementia, neurodegenerative diseases, or mild to moderate organ failure. As long as you can still talk, sometimes even motion or blink, the healthcare system is going to try and get your consent for all procedures. So when we're talking about these situations, you are not able to speak for yourself. Consider your advance directive or your letter of wishes as your insurance policy to ensure that you get the care that you want, should you not be able to speak for yourself. So this is where I bring up the story of just think about how many times have you driven to Hope? And have you always had insurance? Most of us would never, ever think of even driving 2 hours away, let alone out of our own driveway without insurance. But how many car accidents have you been in? That's what an advance directive is like. The chances that you're going to need it are very, very small, but it is for catastrophes, so that when you get to a certain, you're now on life support, or you're in advanced dementia, that you've had these conversations with people so your loved ones can have some inkling, some understanding of what you would and would not want. You get to choose. In order to do that, you need to be informed and assertive. You will need to have courageous conversations with your loved ones. And sometimes the most difficult is your primary care practitioner or your specialist. Most often, your healthcare team is waiting for you to open the discussions about your preferences for future healthcare. Doing this work is preparation for those conversations. So before we start that, I'm going to just pause the so throughout the next slides, keep in mind 3 scenarios. These are the ones that I use in my advanced directive templates, because they're all different depending on our ages and where we are in our healthcare journey. One of the things that I forgot to put in my previous slides is that you get to change your mind at any time. So an advanced directive is not a static document. It should be changed with every change in your health. So it should be changed. You should think about it every significant birthday, every change in your health status, when somebody you love gets sick or dies, anything that's getting you, that is changing your life, you should be looking at your advanced directive. Every time you go to hospital, you can change your mind. You don't have to take your advanced directive with you. You don't have to do that. So if you're going to hospital and you're having a conversation, let's say you're about to have, this is a real story. One of my clients, a hysterectomy, and the anesthetist actually brought all this up with her. And he said, I noticed that you've put down that you have an advanced directive, you don't want CPR. But I'm hoping that you'll let us do CPR if you need it in the operating room. We have all the equipment available. We can resuscitate you on the spot. This is a lot different than being at home and collapsing in your living room. And she agreed to change it for that period of time, for that hospitalization. So you can change your mind at any time. So the first scenario, if tomorrow, at your current age and your current level of health, what happens if you have a serious health crisis? Examples can be a car accident, a massive stroke, or a major heart attack. So you might say that you don't want to have CPR, that you don't want to be intubated or put on a ventilator, depending on your age, and we're going to be talking about that. But what if you have a stroke and you can get to the hospital immediately and get big blood clot busters and things like that, and you will be able to walk and talk and leave the hospital within a few days? So what about something serious that happens tomorrow at your current stage of health? What about a different scenario? In the future, you were at the end stage of a serious life-ending disease, and you could no longer speak for yourself. Most often, this is due to cancer or a neurological disease. So sometimes it could be a major stroke. That scares the crap out of me. I have huge numbers of people in my family who have strokes, but often cancer can sneak up on us and then all of a sudden bloom, and suddenly we are in a palliative care unit on a lot of pain medications, maybe even palliative sedation, and we can't speak for ourselves anymore. So we're going to address those kinds of things. What would you want in that situation? And third, you have advanced dementia and you are no longer able to care for yourself, recognize your loved ones, or know where you live. These are the 3 major ways that our lives will end. This is as close as we can get to a crystal ball. So in scenario number 1, if something serious and possibly life-threatening were to happen to you tomorrow, what would you want? Would you want to have CPR, to be put on a ventilator, or to be transferred to critical care for increased observation? And the big thing that you can put in your advance directive is when would you want those treatments discontinued? And we'll be going into that. So in order to make these decisions, we must understand heroics. Heroics is the non-medical term for advanced medical support that is usually not only provided in a critical care setting. Heroics are not provided in a long-term care setting. often not even on a medical unit in a hospital. So when you're saying in your advance directive, I would not want heroics, remember that that's just for a little piece of the care that you're receiving in a critical care unit. It includes treatment in a critical care unit, an ICU or a CCU. Some hospitals have step-down units and urgent or advanced care units. So it depends on, but basically it's all critical care. It can include cardiopulmonary resuscitation or CPR, cardiac support, big machines that are keeping your heart functioning, enhanced respiratory support. That doesn't always include having a tube put down your throat. It can be CPAP or BiPAP, which is CPAP's big cousin. It can be artificial hydration. That's pretty much a guarantee. You're going to have IV fluids. Tube feeding is an option, and kidney dialysis. So these are, when we say, I don't want heroics, that's what we mean. We don't want these big things. So, as they say on the news, the following might be disturbing for some people, but this is what heroics looks like. This is an elderly gentleman with a tube down his throat. Can't see all the things that are going on, but in the far corner, there is a ventilator machine that's working for him. That's called an IV tree. That's got multiple IVs going, and as you can see, there are multiple cords and there's multiple things going on. And so when you say, I don't want heroics, this is what you mean, that you don't want. So let's get down to that no CPR order, which is at the top of the list. Well, everyone's heart will eventually stop. It is usually not sudden, and it's usually not unexpected. It's a very, very small percentage of us that will have a sudden cardiac arrest. I think it's something like 2%. So chances are that's not going to happen to you unexpectedly. But having a no CPR or a MOST order, which I'll be describing, is essential if you're sure you don't want to be resuscitated. It's kind of like opening the door to having these conversations. And it says, I've thought about this, and this is not what I want. When thinking about life-sustaining treatment and CPR, here are a few things to think about. What stage of life are you in? If you're over 70 or 75, you should be having this discussion with your doctor. I'm not going to be making that decision for you. I'm not going to tell you the pros and cons, but you need to have that discussion, because the thing that will happen is if your heart is restarted, there is a possibility you will have brain damage. There is a likelihood, it is inevitable, that you will have broken ribs. They will heal. That's not the end of the story. It's actually the cartilage between your sternum, your chest bone, and your ribs that's broken, and that will re-heal. But you will be intubated, you will be put on a ventilator, you will be in ICU, and then the decisions start to need to be made at that point. The person you are right now, you're having a great life, you're having fun, you can't even imagine having your heart stopped. That person will no longer exist at that moment, because when your heart stops, you are technically dead. CPR is prolonging, keeping all your organs and your brain going so that other interventions can take place, so that you can be defibrillated, which we're going to talk about in a minute, so that you can get to the hospital to have maybe a heart stent put in if you've got a heart blockage. So it's buying you time. If you're willing to buy time, awesome, then you should go for it. But have that discussion with your doctor. And do you want quality of life or quantity? If you want quality, think about this deeply. If you want quantity of life, and there are a lot of reasons you might want quantity, you've got a grandchild on the way, you've got a big, you want to make it to your 50th wedding anniversary. Whatever your quantity is, that's as valid as quality. So think about what that might be. Should everyone have CPR? No. CPR can work for reasonably healthy adults. It's usually most effective when initiated immediately after a cardiac arrest. You've got 3 to 5 minutes um, before CPR started to keep your brain alive. So CPR means cardiopulmonary resuscitation to restart the heart and the lungs. It is the manual, aggressive compressions to your chest. A lot of us use the term DNR. It's not exactly the same. DNR means really don't do anything. CPR means just don't restart my heart. So no CPR basically is the same as DNR, or do not resuscitate. I'm pretty particular about my words, so I like you to use the term no CPR. In BC, the official terminology is no CPR, and it's the term I'll be using here. So CPR is usually not effective for adults with medical conditions with damage to their heart, their lungs, the kidney, or the brains. CPR and all the drugs that go with it are especially hard on our kidneys. Adults who are at the natural end of your life. So if it's cancer or a neurological disease, dementia, just plain old age, generally it doesn't work. If you don't want to have CPR, it's important to talk to your primary care practitioner or your specialists. So especially if you are seeing a kidney specialist or a heart specialist, they're the best people to talk to. Talk about the risks versus benefits of resuscitation. And your doctor might say, you know what, you're only 62 years old. Your chances of surviving CPR and having a good life are great. Yeah, you might have broken ribs for a little while, but is that the chance that you're willing to take? And they will have these discussions with you. Whereas when you're 85 or 90, that conversation might be a lot different. No CPR is for the community when you're home and out about in the world. So you've had a cardiac arrest and you've collapsed and you're in front of your fridge, or you've gone out to the frozen and you're in the frozen pea aisle of Safeway. And that is a real story about a man who collapsed in the frozen pea aisle. And he said, I think my heart's going to stop. I don't want CPR. He didn't have an order. And so when the first aid attendant told the paramedics, he told me he didn't want CPR. They had to go ahead and do it because he didn't have an order on him. So we're going to get to that in a minute. So medical orders for scope of treatment are generally for facilities in hospital and residential care, or while receiving palliative care and hospice, either at home or in the facility. And as I said, we're slowly transitioning away from an OCPR order and having most orders available in the community as well. So if you do not want CPR in the community, at home or out and about in the world, in BC, you must have a signed doctor's form, either a no CPR order or a MOS form. Your loved one cannot tell paramedics you would not want CPR. So in the education blog, in the book, or just Googling no CPR order BC, you will come up with this PDF, but your doctor also has access to it. You must have a no CPR order signed and available with you all the time, or have an official medical alert bracelet on. And the only way to get that bracelet is to send your MOS form or your no CPR signed orders to medical alert. And it will be a special alert bracelet that has your name so that nobody can steal it from you, and it has no CPR on it. You can't go to your local jeweler and have them done. It's like a no copy key. They are not allowed to do that. So having this written on an advance directive is not enough. That's good for the hospital. It's not good enough for the community. This is what the form looks like. So if you just go to HealthLink BC or just BC No Cardiopulmonary Resuscitation, this form will come up. Okay. Whitney, can you just tell me what the chat was about?
There are some details that Tambelinda has shared from some studies.
Okay, great.
So
She'll
it's
go
got some
into those
stats and
later.
details.
Okay, great, thanks. So we're going to talk about defibrillation because this is a big one these days. You might not want to have CPR, but defibrillation should be another option altogether, and I'm going to go into that. So you might have seen this little handy thing. Every big store has them. They're usually by the produce section, just inside the back doors. A lot of apartment buildings have bought one or two, and there should be a sign where they are. All hockey arenas have them. They're popping up everywhere, and they're quite affordable. So if you do live in a condominium and you don't have one, you might consider getting that. Because as I said about CPR, CPR is kind of the placeholder to keep you alive until something else, other interventions are put in place. This is the intervention that is put in place. So when I was a nurse, I was a cardiac nurse, I probably did CPR 100 times. I had, when we only did CPR, I had one patient who survived, went to critical care, but never left the hospital. But when I had a patient in an abnormal heart rhythm, brought all of them back in order to send them off to a critical care unit and for more interventions. It just brings your heart rhythm back in line. So when you're writing an advance directive, one of the options will be allow defibrillation for an abnormal heartbeat. If you've got questions about that one, please stick it in the chat and we will talk about that in a little bit. So defibrillation is a series of electrical shocks to the chest to reset the heart's rhythm. While defibrillation is used when someone has a lethal or life-ending heart rhythm or cardiac arrest, there are often non-life-threatening rhythms such as uncontrolled atrial fibrillation that are often easily corrected. It's recommended that you have discussions with your physician before refusing defibrillation. So respiratory assistance and oxygen. We have to have oxygen to live. Not having enough oxygen causes air hunger and physical and mental distress. When oxygen is provided through tubes in your nostrils, a mask on your face, or a tube into your lungs, it can help keep you alive, but it also relieves suffering. Oxygen at the end of life is considered comfort care. It will not keep you alive, but it will relieve suffering. Some people don't know what ventilation is. A lot more of us learned about it during especially the beginning of the COVID pandemic, because we were assaulted by it on the news pretty much every night, seeing images of people on ventilators. It's actually one of the big reasons that I want you to think carefully and about things, because we don't know what will be changed in the future as far as medical care. And one of the big things that changed during the COVID pandemic within months was the ability to provide more oxygen without sticking a tube down somebody's throat or using artificial ventilation. So this is probably one of the places you really want to have the discussion. It's one of the things that Dr. Bigham, who is an ICU interventionist in Toronto, brought up. He said, sometimes being on a ventilator for 4 days while we give you heavy duty antibiotics can keep you alive and while you're fighting your pneumonia. And so be careful about saying that you would or would not want to be put on a ventilator. Sometimes that is a really important thing to have happen. So it can be something that you want to talk to your family about. With invasive mechanical ventilation, a tube is inserted into your mouth or your neck and into your lungs, and a ventilator machine assists you breathing or breathes for you. It gives your lungs, heart and brain a chance to rest and to heal. The patient is usually kept medically unconscious during this time. So your representative and your substitute decision makers are going to be very important when you are unconscious, either because you're naturally unconscious or because they put you in a coma. So this is what it looks like. There's a tube that goes, an endotracheal tube that goes in, air is flowing in, and you're exhaling air out. So most of us know about non-invasive oxygen. Probably watch TV shows, or maybe you've been in the hospital and you've seen people with the tubes in their nose. These are called nasal prongs for low percentage oxygen. It's all that most people ever need. High flow oxygen is high percentage, up to 100% oxygen delivered via face mask. CPAP is continuous positive pressure via nose or face mask with additional oxygen attached if needed. BiPAP is biphasic, so the mask is going positive pressure in a face mask with additional oxygen. That's only, CPAP can be at home, BiPAP is only in hospital. The patient may still be conscious for all of these. In fact, they're encouraging people to be conscious when this kind of thing is going on so that you can do deep breathing and you can do coughing and be actively involved in rehabilitating your lungs. So these are the pictures. So that's what nasal prongs look like. There's high flow oxygen by those tubes, CPAP, and a ventilator.
Connie?
So I'm gonna, yeah.
We have a couple of questions that relate to this, so I think this would be great. So Tamalinda's asked some great questions. Thank you. First one is there a trauma associated with having had defibrillation?
That's a really good question. Is there trauma with defibrillation? Yes. It's not,
Okay.
it
Short
doesn't,
answer.
yeah, it doesn't last long, but people do feel that they've been kicked by a mule. And in the two spots where the pads are put on, there's nearly always a burn mark. It's first degree burn, rarely a second degree burn, though I have seen people who are extremely fair skinned, redheads, who will actually develop blisters from where the pads were. If you've seen it happen on TV, the person actually rears off the bed for a moment. It's a bit exorcist-like. And so sometimes people will feel pretty sore. Their whole bodies will feel sore afterwards. But if you're awake enough to feel that you've been kicked by a mule and have two-place sunburns and you're a little achy, you're alive to feel it.
Very good point. Very, very good point. The second question has to do with mechanical ventilation. So Tamalinda's asked, this is a couple of parts, well, a question with kind of a couple of sections here. Is there resulting trauma with having had defibrillation? Mm-hmm. They sedate you for it, and I understand there can be physical injuries as a result, broken teeth, throat injuries, etc. But is there emotional trauma afterward? This is with mechanical ventilation.
There is certified post-traumatic stress from being in an ICU. That is has been well documented now. The lights are always on, the noise is always on. There are people who are dying around you. They're talking, and the nurses and doctors are talking in loud voices about you and everybody else. I haven't heard of it happening specifically because of intubation or being on a ventilator, other than that's part of the ICU experience, and people are very often aware of their surroundings. They might be deeply sedated, but hearing is the last thing to go. Denise, I'd love your input on this.
Well, and we have another question too.
Okay.
So, and I think this relates to the conversation around ICU, is a concern around brain injury as a result of being in the ICU, typically as a result of not getting enough oxygen. Is this correct?
I've seen people have pretty low oxygen levels, whose brains are still working. But I would think that the trauma comes from the CPR specifically, and not having received enough brain oxygen to your brain during CPR.
Excellent answers to great questions. That's it for the questions currently in the chat.
Right. Anything you wanted to add to that, Denise?
I'd like to share one story, and I think because it bears the importance of a couple of things. Number one, medical care is changing rapidly, and this was part of my discussion when we were talking about technology and how it is changing. And not only are the drugs getting better, but the processes and what they're doing and how they're doing them, especially when it comes to CCU and ICU, and that's awesome. Some of the trauma isn't necessarily just to the patient themselves. CPR in particular, like you said, you put it very nicely when you said it was aggressive. I'd say it's probably a little bit more than aggressive. It ranks right up there with violence, and it's very, very hard to watch. It's hard enough for the healthcare providers to be doing it physically, but it's a very, it is hard to watch. Is it successful when you have people like the young, robust person who something happened and we get started at it real fast and get them transferred where they can get a lot of help? Yeah, it is. The speed is really of essence. It is super important. And again, when you spoke about the defibrillation, I can't agree with you more. More people are going to suffer from irregular heart rates, and that can easily be straightened out by having defibrillation done. That is more often the reason why they collapse in the freezer aisle, rather than a full-on cardiac arrest. So it's important really to look at these things on an ongoing basis, like you said, because things are changing quickly, and
Yeah,
it also depends
especially
on
in a
where you
critical
are.
care setting. That's
You
where
best.
the money, that's where the research is being done.
Yes, it is. Yeah.
Yeah, thank you.
And so as a clarifying point, Denise, you mentioned the CCU and the ICU. And so Tamalinda has asked, what's the difference? Which makes sense. It's a bit of our medical jargon.
So I'm the person who put that slide up. So I'll start with that and let me know.
There you go.
It depends on the hospital. So at Vancouver General Hospital, there is a section for critical care that is the size of 3 city blocks. It is massive. There's a burn unit. There's several critical care units. There's an ICU. There's a cardiac intensive care unit. There's all those things. All of those are critical care. So if you've got one nurse to one patient, or maybe 2 patients to one nurse, and there are machines and they are looking at you're on the monitors and they're looking at all that stuff, that is critical care. Intensive care unit in the Vancouver General Hospital world means that you're on a ventilator. So that's the top of the top of the top. I had a client in Mount St. Joseph's Hospital for a month, and it was called the high acuity unit. They had the monitors, but they didn't have all the big machines. Basically, it's the number of nurses and the number of doctors per patient. Anything to add to that, Denise? Good, good. Okay. Thanks so much for chiming in. Was there anything else that we wanted to chat on? So I hope I answered the difference is basically it's whatever they want to call it.
So that's very thorough and a little bit flexible. That's it for the questions in the chat.
Thank you. So understanding critical care, I'm going to get that into a little bit more. I believe that every adult who lives in the community, who has a good quality of life, and does not have a life-ending diagnosis should opt for critical care. Stating this option does not mean you will be transferred to a higher level of care. It means that this is open to your healthcare team should you need it. The older you are, the more likely you are to need increased medical and nursing observation. It concerns me when an older adult, and I call this ageism, is put onto an older adult medical unit. The number of nurses per patient is way lower. And to me, an 80-year-old or a 90-year-old who's got dementia or let alone delirium needs more nursing care, not less. But as far as this piece goes, my story is I've had so many of these cases over the last few months, but the most was one of my clients was going for a routine ultrasound in the hospital and had nothing to do with what was about to happen other than she was in a hospital when she had a massive stroke. They immediately sent her to, she was 89 years old. Immediately sent her to the neurological ICU, where they gave her blood clot bussers to get that clot to dissolve. And when I saw her the next day, she wasn't walking, she wasn't talking. The next day I went to see her, she was talking in full sentences. The next day she was admitted, she was discharged home, and she was walking. If she had said, "Don't send me to critical care," she would not have survived. Another client who I went to go and do advanced care planning with, I saw her, I went, "Holy doodle, you need to go to hospital right now." And we phoned the paramedics, and she was in the high acuity unit within, and she had just said, "Don't do CPR, don't put me on a ventilator, but take me to critical care." And she was sent to critical care, and she had multiple clots throughout her body, and she was there for a month, and she got one-on-one nursing care, and she is also back home. So critical care is really important. Denise.
I want to chime in here because sometimes, like, we're talking about some of the bigger heroics, but some of the things that you've mentioned, the oxygen and the hydration, I can't stress how important those two things are. Most of the things we get scared about going into healthcare is, or into the hospital, is the amount of pain that we're going to be in, and not being able to do things because we're in pain or we're not controlled. If you have proper hydration through IV, and if you have proper oxygen intake, the pain medications are going to work a lot better than what they would if you didn't have those. So even some of the more simpler heroics, some of the simpler ideas here will help alleviate a lot of the things that people are actually scared of, which is the amount of pain, the fact that they can't move. And some of that's just because they can't, they're feeling so much pain. So I wanted to stress that sometimes we need to really look at what is it that we fear, and if it's, and what can be done. Like I said, some of those drugs are great, but if we are hydrated, well hydrated, and we are have a lot of oxygen, we're going to be in better shape.
There's a comment that somebody has a DNR and it really means do nothing. You need to put that in an advance directive. You need to write that out. You need to say your values and beliefs and exactly what you put in the comment, which is, you've had multiple health issues and those kinds of things. One of the stories about that before I move on is one of my clients, she was in a similar position. She was in her early 60s. She looked healthy, but she had a genetic heart disease that and her cardiologist said to her, if you have CPR, you are not going to survive this. And so we did an advance directive. We did the no CPR. And we wrote down her values and beliefs around that so that they weren't dismissing somebody who was 62 years old, who looked healthy. Why does she not want to be resuscitated? Why does she not want to do the anythings? And I've had several people who have advanced Parkinson's that they're managing at home that they know wouldn't be managed in the hospital as well as they manage it. And they've made the choice that they absolutely do not want to go to hospital. And one of the things that I would encourage you to work with me or Whitney with is that what do you have in place so that you can stay at home? What do you have in place so that you can stay in the community and you don't need to be transferred to hospital? Because once you're admitted to hospital, all those things are going to ramp up. Okay.
And just as a related topic, because we've mentioned hydration, Denise, great point. A couple of people have noted some thoughts around hydration. First of all, one has asked, Tamerlane asked, is it automatic? Like, does that just kick in? Is an IV line a standard procedure? And is that something that at end of life, when hydration is not good for the dying body, it can actually physically hurt and or prolong things, if you could address that. And also, Sandy asked, how do you make sure the hospital ward is adequately hydrating and oxygenating your loved one?
Yeah, again, that comes down to the level of nursing care, really. Number one, is hydration automatic? Nearly always. But not at end of life. So as you are going gently into the good night, that's one of the things that's going to be discussed, is whether you want that. If you're in a palliative care unit, you might get IVs to deliver pain medication to relieve some of your suffering, and we'll go into palliative care some other time, but palliative care is not hospice. Palliative care is pain and symptom management. If you go to a hospice, you absolutely will not have an IV. It's just not, that is considered active treatment and it won't happen. But when you go into hospital, for exactly what Denise said, is that it reduces, number one, it helps your kidneys function. And it relieves suffering. Being thirsty, even if we don't feel thirsty, can be awful. Delivers pain medications, and it delivers antibiotics, keeps your blood vessels nice and plump so that they can deliver other forms of treatment. So for a basic admission hospital, yeah, IVs are absolutely essential. And as a family, it is your job to advocate to make sure that your person is hydrated and having enough to eat when they get to a unit. Do I wish I didn't have to say that? Absolutely. But when somebody is old and frail and they're not feeding themselves, it's not the nurses who are delivering the trays, it's somebody from the kitchen. They're not setting that person up properly. They're not getting rid of all the cards and the flowers and the mess that's on the overbed table so that somebody can get to their meal. They're not doing all those things. It's so important. And if you don't have people you don't have family who can come to get you to be with you, I cannot encourage you enough to build community now so that you can have people come in and be that, because our healthcare system is broken and there are not enough nurses and there won't be for some time. And so it's up to us to make sure that ourselves and our loved ones have that basic kind of care, because our nurses and our doctors are looking at a higher level of making sure our vital signs are okay and that we're going for operations and those kinds of things. They're not so focused on how much of your overcooked macaroni and cheese you ate. And then final question before we move on.
Several people have shared some really personal stories in terms of what DNR means to them, and so I welcome everyone to read those in the chat. And also a note that Tamalinda mentioned in terms of advanced care direction or a directive, or in Ontario it's called an advanced care plan document. Some that are extremely long, where a brief bullet point cover page is essential because the medical practitioners simply don't read the longer form.
Exactly.
And I have noted that that is a similar pattern here.
Yes, exactly. And so it's one of the reasons I don't like lawyers doing them, because it's hidden on page 4. Even if
Yes,
it's
after a lot of
flippant.
other text that might not be related. So yes.
Okay, so let's move on because I know that we're running out of time. So critical care, basically went over this before. Intensive care unit are ventilators and life-preserving equipment, monitors, and one-to-one nursing. Critical care in some big hospitals with everything except ventilators. Again, 1-to-1 or 2-to-1 nursing, and step-down units where there are monitors and 2-to-1 nursing. That's the kind of nursing care that I did for 15 years, as a cardiac step-down unit. They're still critical care nurses, they just have a few more patients. Okay, whoops. So reasons that you might need critical care: postoperative delirium, which is severe confusion. That's very, very common in older adults, especially when you've had something traumatic, like you've fallen and broken a hip, you suddenly need surgery. Urinary tract infections, probably #1 cause for delirium. You're trying to crawl out of bed and you're pulling your clothes off and you're pulling out all your IVs and all that kind of stuff. That can be a really big issue when you're trying to heal. Post-stroke treatment and observation and post-heart attack treatment and observation are often reasons why you'd need critical care. So artificial hydration equals intravenous or IV fluids, and artificial nutrition equals tube feeding. We need hydration to live. Without fluids, our organs will quickly begin to shut down and die. When we are unable to drink enough, they are administered via IV. If we are approaching the end of our life, refusing food and fluids is a natural response. And most healthcare professionals, especially when you're in long-term care, palliative care, or hospice, understand this process. Thirst naturally declines or goes away at the end of life, and that can be uncomfortable for loved ones. In fact, I can guarantee it will be uncomfortable for your loved ones. There are things that we can do to make it look better as the mouth begins to dry out, but they are not suffering when this is happening. By stating that you refuse fluids when you can no longer drink, you need to acknowledge that you understand this will lead to your death. If you cannot drink enough, eventually your kidneys will shut down. We need nutrition to heal. If you are in critical care and unconscious and unable to eat, you will need tube feeding in order to heal. If you are approaching the end of your life and you are unable to eat, would you want to be spoon-fed? That's a very tricky question. And often that should be a conversation that your representative or your substitute decision makers are making with your healthcare team at the time. So I recently had a client who was dying of Lewy body dementia, one of the most aggressive forms of dementia. And he had said to his sister ahead of time, I am afraid of starving to death. Food was one of his big comforts, even when he can no longer communicate. And he really enjoyed his food. In fact, he put on 50 pounds in the last year because that's the one thing that he was enjoying. And if he had said that he didn't want food or fluids, he would have missed out on that one piece of quality of life. But what happened was eventually he was starting to have aspiration pneumonia because his swallowing reflex was being compromised. And then his swallowing reflex stopped altogether. And so we had no choice but to not feed or give him fluids for the last week of his life because he was not able to take them safely anymore. By stating that you refuse spoon feeding, and for some people that's important, when you can no longer feed yourself, you will need to acknowledge that and understand that you understand this will lead to your death. And I want to say that sometimes that's an exit plan. That's an exit strategy for you to write. If you're getting to the end stage of dementia that is an exit strategy to no longer be fed. Understand that that can be traumatic for the people who are around you, even your paid caregivers. Very few of us are going to need dialysis or kidney support, but it can be short-term for acute or sudden health event. Often the technical term is the kidneys have taken a hit, and that means that they've been given drugs or a trauma that have caused them to just kind of shut down. They're in shock and they'll come back. So sometimes short-term dialysis is appropriate. Long-term is for severe permanent kidney failure. And these kinds of conversations will take place with you while you are capable. A doctor is not going to suggest that you are put on long-term kidney dialysis without your consent, and your representative can't make that decision for you. So
What about hello?
Yeah.
What about if you have this will, living will, and you say you don't want to be on big machines for long term of period, maybe maximum of 1 week?
So, long-term dialysis is not part of an advance directive because you must be capable of having the discussion. If your kidneys are failing, and you must have a discussion with your of risk versus benefit of peritoneal, which is into the abdomen, or hemodialysis, which is your blood, with your nephrologist, which is your kidney specialist. If you don't know what any of those terms mean, it's because you aren't in kidney failure. If you are in kidney failure, you're going to get to know those terms really fast. You have a choice. Be assertive in getting and receiving all the information. So medical orders for scope of treatment, known as MOST, and your advance directive or living letter of wishes. Most are medical orders for level of treatment and resuscitation. They're used in hospital, residential care, palliative care, and hospice. As I said, in Providence Health, which is the Catholic hospitals here in Vancouver, those are known as goals of care, which quite frankly, no, actually, I need to change that. It's code status, which makes abundant sense. If you have an advance directive or a letter of wishes or a living will, it is to be used in conjunction with MOST to facilitate conversations and decisions. So many doctors have said, oh, we don't need your advance directive. We've got this MOST order. The MOST order is in medical gobbledygook. It uses really big words, and it doesn't talk about your values or beliefs at all. It doesn't talk about when you will want things stopped. It doesn't talk about who you want informed. It doesn't talk about the comfort care that you might want. So it's really insist. And as Whitney will tell you, if you are in a hospital and nobody's paying attention to your advance directive, to your representation agreement, to your advanced care planning documents, ask to talk to the social worker. They are trained, they're highly overworked, but they are trained in advanced care planning. Your advance directive will likely include your values and beliefs and instructions, so it's meant to be paired with MOST. MOST has 6 levels. 3 are critical care, 3 are medical care. When I'm helping people with advanced directives, I tend to stay in the critical care part. Often when we are in a long-term care facility or in palliative care, we are maybe not so able to make these decisions by ourselves. It's where our substitute decision makers and our representative need to chime in. So I'm just going to quickly go through this, and we'll work on this next week. That if you do not have a MOST order put in place, or if nobody has talked to you, everybody is assumed to be at the highest level, which includes CPR, being put intubated and being sent to critical care. So unless you have this discussion, this is where you will land, even if you're 98 years old. hopefully somebody has figured that out. You're 98 years old. Maybe we should have this discussion with you. And then the highest level, there's the highest level of care without CPR, but with ventilation. And then there's the highest level of care without CPR and without ventilation, but still allow critical care. So the medical levels, there's no resuscitation, no transfer to critical care. The highest level in the M's, and we call it affectionately M1, 2, and 3. M3 is, or M1 is medical care and allow transfer to hospital. If you've got somebody who you love who's in a long-term care facility, they will automatically want to put you in an M2 level, which is approaching end of life. Long-term care is considered a palliative care unit. It's the last place where people will live. But that doesn't mean that you might not need to go back to hospital. And so think about that and don't automatically say, oh, sure, M2. You want an M3 so your person can go back to hospital and get maybe a blood transfusion if they're anemic, IV antibiotics if they have an infection that's not responsive to oral antibiotics. If they've got a pressure wound that is requiring more care than can be provided in a long-term care unit. So there are reasons, like so my one piece takeaway from this is if you've been handed a medical orders for scope of treatment for a loved one and say, please sign it, ask questions. M2 is approaching end of life. Do not perform CPR or resuscitation. Symptom management and supportive care only. Do not transfer to a higher level of care, which is hospital. And then end of life care is do not perform CPR or resuscitation, symptom management and supportive care only. So somebody is considered hospice at this level.